Okay, let's get right into it. When we're scanning the chest and we find a pleural effusion, our job is far from over. In fact, that's really just the starting line. The true power of bedside ultrasound is in characterizing that fluid, giving us major clues about what's going on and, more importantly, how we should manage it.
So, the real question we're digging into here is this. Once you've answered, yes, there's fluid, what else is the ultrasound telling you? We're going to move beyond simple detection and get into detailed characterization. And that's the key to making smarter, faster clinical decisions right there at the bedside. So here's our game plan. We'll start with a general overview of characterizing effusions. Then we'll break down the three big sonographic patterns you're going to see: the simple anechoic, the more complex echogenic, and the really organized septated effusion. And finally, we'll tie it all together, linking the image you see directly to the intervention you choose.
All right, first up, characterizing pleural effusions. It's really important to think of these findings not as three separate boxes, but as a spectrum. The appearance on your screen often mirrors the progression of the disease itself.
Now, this table is basically the cheat sheet for this entire talk. On one end of the spectrum, you have your anechoic effusion, totally black, classic for a simple transudate. Then, in the middle, things get a bit murkier with the echogenic effusion. You see internal echoes, which should make you think exudate. And at the far end of complexity, you've got the septated effusion, full of fibrin strands, which is a huge red flag for a complicated process like an empyema.
Let's start at the beginning with the simplest form, the simple or anechoic effusion. This is that classic, uncomplicated picture we often see first.
So the term itself, anechoic, literally tells you what's going on. It means without echoes. The physics here is pretty simple. The ultrasound beam does zips right through this thin, watery fluid without bouncing back. And what do you see on the screen? A uniform, jet black space.
Clinically, this is the textbook look of a transudate. Think heart failure or cirrhosis. But here's the critical pitfall you have to remember. Up to 40% of exudates can also look anechoic, especially early on. So while it suggests a simple, non-inflammatory process, it absolutely does not rule out something more sinister brewing. You'll see this fluid is free-flowing. It'll swirl around and change shape when your patient breathes or rolls over.
All right, now let's level up in complexity to the echogenic effusion. And I love this subtitle. You are literally seeing the cellular story unfold on your screen. So what do we mean by echogenic? The fluid is still mostly dark, hypoechoic, but it's not pure black anymore. It's now filled with these visible little specks, these internal echoes. The key thing that separates this from our next category is that you don't see those thick, bright, linear strands of fibrin just yet.
It's clinically important stuff. Those little echoes are reflections from cellular debris, red blood cells in a hemothorax, pus in an early empyema, or bits of fibrin. Seeing this sign should immediately make you think this is an exudative process. It's a clear signal that something inflammatory is going on, even if the fluid itself can still move around a bit.
And that brings us to our third and most complex category, the organized or septated diffusion. This is what happens when the inflammatory process goes into overdrive and fibrin starts building actual walls inside the pleural space.
The hallmark here, the thing you cannot miss, are the septations. These are bright, linear echoes, thick strands of fibrin that stretch all the way across the fluid collection. They act like walls, chopping up one large effusion into many small, trapped pockets of fluid. This is what we call a multiloculated effusion. And the clinical significance of seeing this is enormous. It's highly specific for a complex exudative process, and it's a key finding in something like an empyema. Now, because these fibrin strands are trapping the fluid, it's no longer free-flowing. So the big takeaway at the bedside is this. Seeing septations is a powerful predictor that your standard simple thoracentesis is probably going to fail. You just can't drain all those little pockets with one needle.
And listen, this is a high-yield clinical pearl I really want you to take home. When it comes to finding these critical fibrin septations, thoracic ultrasound is king. It's not just as good as a CT scan. For this specific question, it is the superior imaging modality. It's simply more accurate. Why? Because the real-time dynamic nature of ultrasound lets you see these fine web-like strands floating and moving in a way that the static slices of a CT scan just can't capture.
Okay. So let's bring it all home. This is where the rubber meets the road. We're going to tie everything we've seen on the ultrasound screen directly to our clinical actions.
So let's just walk through this one more time. You see a simple anechoic effusion, you're thinking simple process and a simple drainage should work. You see echogenic fluid, that plankton sign, and you know it's a more complex, inflammatory process, and you need to start thinking that drainage might be tricky. But when you see a septated effusion, that confirms an organized, loculated process, and you should be planning for advanced intervention right from the start. We're talking a chest tube, maybe fibrinolytics, or even a call to surgery.
So I'll leave you with this question to take back to your next shift. Knowing this, how will moving beyond just saying, yes, there's fluid, and instead using this refined characterization, anechoic, echogenic, or septated, change your next clinical decision at the bedside?